Today my goal is to help you understand the intricacies of abutment screw loosening and fracture and the process of keeping them securely tight. Before we start, I would like to emphasize that this masterclass is specifically designed for intermediate and advanced level implant dentists who may be struggling to comprehend why their patients' implant prosthetic screws are becoming loose and are breaking, and more importantly, how to prevent this. Like all my lectures, we communicate in plain language to enhance understanding. However, please note that this masterclass contains highly technical information and is not intended for patients nor junior dentists or dental students. I have two other videos which I will provide the links to in the description below that are much shorter and are aimed at informed patients, dental students and junior dentists covering the same topic. As we step into the realm of dental implants, it's crucial to recognize that we are entering into the domain of biomechanics. Long-term success in this field is a delicate balance, with 50% reliant on medical knowledge and the other 50% hinging on engineering principles. While our dental training equips us with a strong foundation in medicine and dentistry, it's important to acknowledge that we do not receive formal training in engineering in our dental course. Nevertheless, understanding engineering concepts is paramount to achieving success in biomechanics. In today's discussion, we will primarily emphasize these engineering principles and concepts. It is also important to understand that the information presented in this lecture should be watched and understood before diving into the following masterclasses that I will put on the screen below. The objective of this lecture is to uncover and quantify the occurrence of complications related to abutment screw loosening and fracture, addressing the ongoing debate and discrepancies in opinions amongst researchers. 2. To investigate the phenomenon of abutment screw loosening and its potential ramifications, especially within the complex framework of the implant abutment-prosthesis complex, known as the IAPC. We will explore the various perspectives and theories put forward by different authors regarding its causes and development. 3. We will conduct an in-depth examination of the chemical composition of abutment screws, abbreviated as AS, as documented in the literature. This is a critical analysis due to the limited research on the presence of metallic particles which have been observed in the peri-implant mucosa surrounding titanium dental implants, a topic that has received surprisingly little attention. 4. We will delve into the comparative valuation between gold alloy, abbreviated as GA, and titanium alloy, abbreviated as TA, to determine which material demonstrates superior performance in mitigating abutment screw loosening within the implant abutment prosthesis complex. And 5. Provide comprehensive clinical guidance for minimizing the occurrence of abutment screw loosening. This complication poses significant challenges and financial burdens. I often humorously remark to my colleagues, whom I've had the pleasure of mentoring over the years, that all my grey hairs can be attributed to this particular issue. Fortunately, I can now confidently say that I've mastered the art of handling this potential complication, and I am no longer adding to my collection of grey hairs. Let's please have a laugh. Thankfully, I get my hair cut short. By way of practical example, I will often refer to this simple nut and screw during this conversation because it makes a lot more sense to have like a practical example that we can easily relate to. One of the most significant challenges in the literature is to determine how common is abutment screw loosening, and this was already stated in 1998 by Taylor. On the one end of the spectrum, some authors argue that it is not a complication but rather than an annoyance. However, common sense suggests that it disrupts workflow, has financial implications, and more importantly may indicate imminent fracture of the implant abutment prosthetic complex, as reported by Goodacre in 2003. He reported that the average loosening rate with single implant crowns using original screw designs was 25%. However, when data from 6 recent studies was combined, the mean incidence dropped to 8%, indicating a substantial improvement with new screw designs. Various authors have reported different frequencies of abutment screw loosening, ranging from 8.8% by Jung in 2012 to 38% by Becker in 1995, leaving clinicians unfortunately confused. So somewhere between 8 and 35%. In the early days of implant restorations, classical abutment screws were made of gold, considered the premium standard in restorative dentistry for securing abutments to implant fixtures due to their superior engineering outcome, including favorable preload, Young's modulus, and the coefficient of friction. Don't worry, we will describe all of these technical principles in simple and great detail. Preload is a term defined as the internal application of stress to an implant system. In recent times, there has been a shift towards using titanium alloy instead of gold alloy abutment screws to restore implant crowns. This shift is primarily driven by clinicians seeking more cost-effective options, as allegedly stated by implant manufacturers. However, others cite the work of Tsugi and Hagiwara in 2009, which suggests that titanium abutment screws are less likely to come loose than gold abutment screws. We will analyze this data to determine its accuracy. Despite an extensive literature review using PubMed, no prospective or retrospective in vivo studies comparing the performance of gold versus titanium abutment screws in relation to abutment screw loosening and fracture were identified. To help clinicians understand the intricacies of abutment screw loosening and the process of keeping them securely tight, we need to review the mechanisms of screws as discussed in scientific articles. Additionally, it is crucial to have a clear understanding of the technical anatomy of a classical abutment screw, as the descriptive terms used can be confusing for clinicians. To simplify this, I have compiled this information into one diagram for the ease of reference and understanding. So this is the technical anatomy of a classical implant abutment screw. Please note that we refer to 3 major parts in the anatomy: the head, the neck, and the threaded part of the screw. When we look in more depth at the threaded element of the screw, we note that there is a crest, a thread root, a pitch, and a thread angle. And we will discuss in more depth why this is important further on in this lecture. Several scientific authors have identified factors that contribute to abutment screw loosening. For instance, Ziedzik in 2012 reported that the success of the screw joint depends on properties such as elasticity, modulus, composition, clamping of the parts, screw head design, strain, finishing of the interfaces, and the presence of lubricants. An interface is defined as the point where the 2 systems meet, in other words, the abutment and the implant body, while a lubricant is a substance used to reduce friction between the abutment screw and the implant body. Prithviraj in 2012 reported that the implant abutment interface determines the lateral and rotational stability of the implant abutment joint, which is crucial for the prosthetic stability of an implant. Supported restoration. Bourget in 1994 noted that lubricating the screws reduces friction, resulting in higher preload for the same torque value compared to non-lubricated screws. Torque is a force that causes rotation. I have identified 20 factors from the scientific literature that are important in the understanding of abutment screw loosening, and we will discuss each of these factors in depth and explain their clinical relevance. The factors include clamping force, torque, preload, excessive bending, settling effect, also known as embedment relaxation, wet lubricants, abutment screw coating, also known as dry lubricants, metal fatigue, clockwise and counterclockwise moments, consecutive loosening and retightening, external and internal hexagon flat connections, and micro gap formation, conical connections and conical connection types, and micro gap formation, abutment screw alloy composition and tensile strength, galling, number of abutment screw threads, number of implants and diameter, prosthetic design and occlusal table, abutment and screw head interface, screw head and body design, and finally abutment screw flanks connection with the implant internal thread flanks. Now let's delve into these details. A review of the study conducted by Siamos in 2002 brought to light the following key points. When two components are fastened together using a screw, this assembly is referred to as a screw joint. Similar to this. The loosening of the screw occurs only when external forces attempting to separate the components surpass the force that hold them together. These forces striving to pull the parts apart are known as joint separating forces, while the clamping force is what maintains their connection. Consequently, the clamping force is defined as the force that firmly secures the abutment in the dental implant. To prevent screw loosening, it's crucial to ensure that the separating forces remain below the threshold of the clamping forces. If the joint remains intact when subjected to external forces, the screw will not loosen. Therefore, the primary factors that play a pivotal role in the keeping of abutment screws securely fastened are as follows: maximizing the clamping force, minimizing joint separating forces. For a reliable implant abutment assembly, screws must be tightened to generate a clamping force that exceeds the external forces attempting to separate the joint. In the context of a sturdy screw joint design, the most critical consideration from a functional standpoint is the initial clamping force produced when tightening the screw. Joint strength is more influenced by the clamping force than by the tensile strength of the screws. Typically, the clamping load is proportional to the tightening torque, with the tensile strength denoting the material's resistance to breaking under tension. Torque serves as a convenient and measurable method for achieving the desired tension. It's worth noting that applying too little torque will lead to joint separation, screw fatigue, failure or loosening, while excessive torque beyond the metal's tensile strength can result in screw failure or thread slippage. Fatigue refers to the weakening of the metal due to repeated stress variations. Administered torque creates preload, which represents the initial load on the screw. I want to digress for a quick moment to share with you an important technical tip. I attended a lecture many years ago that was hosted by a leading prosthodontist, where he was boasting that he would exclusively torque down his abutment screws by finger pressure, and he could reliably, repeatedly, and accurately deliver the correct torque. My wife has an interesting statement, which is, there is fantasy and then there is reality. In short, common sense is not that common. And in the science of implantology, these abutment screws need to be torqued down using the correct drivers plus the correct torque wrench and the correct setting as per the manufacturer's guidelines. If your technician has provided you with a bespoke abutment screw that falls out of the catalog of your regular implant system, for example a hex lobulus system like Nobel Biocare angulated screw channel, or Dental Smart or dynamic abutment solutions, double check that it is compatible with your implant system, and more importantly, check the technical data to see what is the correct and recommended torque. Different implant systems from various manufacturers recommend specific torque values for their screws. The efficiency of a material in converting torque to preload has been described by Tam and Nichols in 2001. Hark in 1995 reported higher preload values with gold alloy abutment screws. Preload is introduced into the screw during the tightening process and serves to keep the screw threads securely fastened to the screw's mating components. This generates a clamping force between the screw head and the seat, causing the screw to elongate and create tension in the flanks and the threads. The elastic recovery of the screw generates the clamping force, ultimately pulling the prosthesis and the implant together. To maintain the stability of screw joints and prevent separation, it is essential to preserve preload and minimize fluctuations. Several factors, including settling effect, preload, and screw geometry, play a critical role in ensuring the stability of the screw joint. Implant interface design and the precision fit of the mating components contribute to the resistance against mastication forces. Two primary mechanisms of screw loosening for implant-supported restorations are excessive bending of the screw joint and the settling effect. Excessive bending refers to a force that can lead to the material failure of the abutment screw. Screw joint preload, defined as the clamping force required to maintain the integrity of the screw joint, has been reported by Tan and Nichols in 2001. The torque applied to the fastening screw is converted into tensile stress in the screw shank, an equal and counter compressive force that holds the two implant components together. The opening or loosening of the screw joint, particularly between a gold cylinder and abutment, has been identified as the primary cause of gold screw breakage. In prosthetic implant connections, two screw joints are of particular concern: the prosthetic gold cylinder versus abutment screw joint and the abutment implant screw joint. The overall stress in the screw joint during clinical function is the result of screw joint preload, stress from distortion due to prosthesis fabrication, and stress from the variable and intermittent functional loading. The metallurgical properties of titanium screws allow for the generation of a more consistent yet lower preload compared to gold abutment screws. This was reported by Dulab in 2014. Ziprick in 2018 mentioned that the preload force of an abutment screw depends on factors such as friction, thread pitch, and tightening torque. Krishan in 2014 noted that the optimal preload for a screw is reached when it elongates until it reaches capacity without extending the yield strength. In an ideal scenario, the preload should be 75% of the yield strength or 65% of the screw's fracture strength. Preload primarily depends on the applied torque and secondarily on factors such as component materials, screw head and thread design, and surface roughness. Screw strength is closely related to the modulus of elasticity of the screw material. The torque values of 32 to 35 Newton centimeters were established based on gold screws made from materials with a low moduli and yield strength. Given the advancements in technology today, it may be worthwhile to reconsider these torque values, and this was reported in 2006 by Permiati. And here is another clinical tip. If your implant manufacturer recommends that the abutment screws can be torqued between a range of, for example, 32 to 35 Newton centimeters. Always choose the upper limit for the best possible outcomes, and we will discuss this more. Occlusal forces play a crucial role in screw loosening of the implants with the hex connections. In these cases, preload is the only force that resists functional occlusal forces and prevents the abutments from separating from the implant. If the occlusal force exceeds the preload, the screw may loosen, and this was reported by Schwartz in 2000. This comprehensive understanding of screw mechanics and the factors influencing screw joint stability is essential for achieving success in implant dentistry. When a bending force acting on a single tooth restoration exceeds the yield strength of the screw, it leads to permanent plastic deformation of the screw, resulting in the loss of tensile force within the screw stem. Plastic deformation refers to the metal's ability to undergo permanent changes in shape. Excessive bending therefore reduces the contact forces between the abutment and the implant, making the screw joint more susceptible to loosening. Another mechanism that contributes to screw loosening is the fact that no surface is perfectly smooth. Even meticulously machined implant components exhibit microscopic roughness, causing the surfaces not to make full contact. Consequently, when external loads are applied to the screw interface, micro movements occur between these surfaces. These movements can lead to wear of the contact areas, bringing the two surfaces closer together. This phenomenon is referred to as the settling effect or embedment relaxation. The magnitude of settling depends on the initial surface hardness and the extent of the loading forces. Rough surfaces and large external loads increase the settling effect. When the total settling effect exceeds the elastic elongation of the screw loses its contact forces and can loosen. And we will discuss the countermeasures to this in more depth a little later. It has been hypothesized that up to 10% of the initial preload may be lost due to the settling effect. Thread friction is highest during the first tightening and loosening of the screw, and after repeated cycles, friction decreases. As a result, the torque required to remove a screw is always less than torque used during the initial placement. This phenomenon is known as embedment relaxation, where the flattening of the surfaces allow the screw's strain to relax, leading to a loss in tension and preload. Consequently, some experts suggest that tightening the implant abutment joint periodically after initial screw insertion. A review by Seding and Mostava in 2019 revealed several influences on the screw performance. The effect of saliva and chlorhexidine, which act as wet lubricants in the implant cavity, on torque and preload remains inconclusive. However, blood contamination of the abutment screw implant interface due to its high protein content and the presence of platelets or fibrinogen may lead to a screw loosening in the clinical practice, as it can result in the formation of a thin film on the surface of the titanium screws. So keep blood away from the screw channel in your implants. Altering the chemical composition of an alloy in an abutment screw and using dry lubricants coated screws can achieve higher preload. Materials with low strength, like pure gold, can serve as an effective dry lubricant. Gold-coated abutment screws have been shown to maintain higher preload compared to non-coated screws. Metal fatigue, which results from cyclical loading and gradual structural damage, is a frequent cause of implant failure. Tightening a screw to the maximum preload within the material's tensile strength can extend its fatigue life, but over-tightening can lead to elastic deformation. Precision and quality in the machining of the implant components affect metal fatigue and the contact precision of the parts during the application of the ultimate torque. Occlusal forces applied during chewing generate bending and twisting moments on the implant abutment connections, influencing screw performance. Therefore, bruxism and parafunction need to be carefully managed in patients with implants, because they have zero proprioception from the implants. And in fact, the data has revealed that patients with implants tend to have even higher occlusal forces than patients that are dentate. The direction and magnitude of occlusal forces and bending moments vary based on the patient's chewing patterns. Clinical practices such as repeated loosening and retightening of abutment screws can lead to smooth micro irregularities on the contact surfaces, reducing the friction coefficient and increasing the preload over multiple cycles. Please note that different implant systems vary in structure, geometry, materials, properties, and roughness, leading to differences in maximum preload torque values. External hexagon and internal hexagon are referred to as flat connections. Flat connection systems exhibit distinct characteristics, and screws from different manufacturers have varying tensile stability. Micro gap formation, particularly in external hexagon systems, is linked to screw loosening, especially when exposed to tension forces different from the axial direction. Microspaces formed within the implant abutment interface due to micro movement can lead to bacterial colonization, mucositis, peri-implantitis, and implant loss in cases of cyclical loads. Understanding these factors is crucial in implant dentistry to address potential challenges and optimize long-term success. Here is a graphical representation of an external implant abutment connection. Please note the abutment in blue, the abutment screw in gold, and the implant body in green. Internal connection systems represent an improvement over the external hexagon system, aiming to reduce or eliminate the micro movements at the abutment connection level and enhance load absorption, particularly when lateral forces are involved. Consequently, internal hexagons theoretically offer a solution to biomechanical complications such as screw loosening. However, it's worth noting that there is a lack of quantitative data comparing loosening between external and internal connections, as noted by Pardal-Pelez and Montero in 2017. Furthermore, Tswaga and Hagiwara in 2009 reported that internal hex implants didn't necessarily provide an advantage over external hex implants when it comes to preventing abutment screw loosening. Here is a graphical representation of an internal implant abutment connection. In tapered conical connections, mechanics play a vital role as both the screw and the conical mating parts of the abutment and implant work together. In these systems, the primary fixation is achieved through frictional resistance between the tapered mating sections, with the screw playing a secondary role, as explained by Schwartz in 2000. Research by Ziprick and Weigel in 2018 pointed out that dynamic loading of 100 newtons or more on internal abutment connections led to cyclical opening and closing of gaps between the implant and the abutment. While these gaps are tiny, they may permit a direct connection between the implant internal cavities and peri-implant tissues, potentially leading to contamination. It is important to note that conical connections demonstrate no or reduced formation of microgaps during dynamic loading. compared to flat connections. Moreover, conical implant abutment connection mechanisms act not only as anti-rotational devices, but also ensure positional stability, reducing screw loosening. Now let's turn our attention. Titanium implant abutment screws are fabricated from various alloys, including titanium, gold, and stainless steel alloys. Gold abutment screws are considered to be the most flexible part of the implant assembly due to their higher modulus of elasticity compared to titanium. This flexibility has a fail-safe effect, as in cases of occlusal overload, the gold screw is more likely to loosen or fracture first. Gold screws are also easily retrievable and can be retightened effectively due to their lower coefficient of friction. Galling is a form of wear caused by adhesion between sliding surfaces. It is a concern with titanium screws due to their lower modulus of elasticity. Gold screws, on the other hand, are less prone to getting galling. The tensile strength of abutment screws depends on the material, with titanium being stronger than gold. Preload in the implant abutment joint should not exceed the ultimate tensile strength of the screw. Manufacturers typically specify torque values designed to generate a preload of 75% of that screw's ultimate tensile strength. Sadly, manufacturers often keep the chemical composition of abutment screw alloys proprietary, making it challenging to discern the frequency of screw loosening in the literature. Additionally, differences in screw design and geometry can vary between lots from the same manufacturer. Personally, I have a big moral and ethical problem with this, and we will discuss this more in length. The success of a screw joint relies on safeguarding preload, which depends on several factors, including the finish of the abutment screw interfaces. Micro-movement between mating surfaces can wear contact areas and lead to closer approximation of the surfaces, reducing the friction coefficient. Thus, clinicians should consider using original components to ensure the best clinical outcome. Flat head screws, due to their reduced surface contact, exhibit significantly less frictional resistance when tightened compared to screws with bevels or tapers. This results in less input torque being lost due to heat and friction, allowing more torque to be transferred into the usable preload. Consequently, flat screw heads consistently offer higher preload levels within a given torque range compared to tapered or beveled screws, making them more stable, as demonstrated by Permiati in 2006. Ziprick in 2018 also observed consistently higher preload forces with flat screw head angles, which they attributed to lower friction between the screw head and its counterbore, thanks to its passive fit. Additionally, Permiati in 2006 emphasized the importance of screw design in preload maintenance. A machine journal, a smooth diameter feature at the end of an implant screw, fits intimately within the implant walls, resisting lateral movement and bending of the joint. The combination of a screw with a thick stem and a journal results in the least loss of torque and the highest joint stability. Here is a graphical representation of a journal on the inferior end of an abutment screw. Classical abutment screws have 6 screw flanks. For clinical applications, especially in patients who brux or have less than ideal implant placement, the use of a thick stem abutment screw with a journal proves beneficial. Some modern screw designs can tolerate torque values of up to 40 or even 50 Newton centimeters without plastic deformation. Using higher torque values can increase preload, enhancing resistance to joint separation and improving abutment screw stability. Tensions induced in a screw, known as preload, keep the screw flanks securely fastened to the internal aspect of the implant threads. As torque is applied, this elongates the abutment screw, placing the screw shank and the screw flanks in tension, which is crucial for bringing the prosthesis and the implant together. The relationship between applied force and screw preload depends on various factors, including shank thread hardness and shank surface finish, all of which affect the coefficient of friction of the screw shanks. No machine surface is entirely smooth, and after the initial torque and unscrew process, there is a flattening out phenomenon of the high spots on the machine surfaces, resulting in more even contact at the flanks to implant thread contacting surfaces. In 2001, Martin investigated the performance of gold alloy versus titanium alloy screws and found that in both types, the screw flank connecting to the implant threads were localized between the superior edge of the screw flanks contacting the middle portion of the implant mating threads. And here is a graphical representation of abutment screw flanks connecting with the implant body internal thread flanks. Please note that the screw is painted in gold and the implant in green. This phenomenon was also identified by Zetzik in 2012. In 2012, Martin also compared gold alloy abutment screws with 0.76 microns of pure gold coating lubricant over the screw flanks to other abutment screws and showed a greater number of mating thread contacts in the gold screws with gold coating lubricant. This finding was explained by either an increase in gold screw elongation or the higher preload value of gold abutment screws. Basic implant system comprises of an implant crown, abutment screw, abutment and implant. And here is a graphical representation of an implant system. It is paramount to understand that an abutment screw doesn't operate in isolation, but rather as an integral component of an implant system. Therefore, it's evident that the performance of an abutment screw is influenced to a varying degree by the other elements of the implant system. In some implant systems utilizing flat connections like external hexagon and internal hexagons, the abutment screw assumes a more pivotal role in securing the implant abutment connection. An examination by Zifrik and Weigel in 2018 revealed that conical connections during dynamic loading produce fewer microgaps in the implant abutment connection. Consequently, in conical connections, the abutment screw plays a less crucial role compared to flat connections. Despite the continued use of flat connection implant systems for historical and technical reasons, it's essential to emphasize that selecting the best possible abutment screw design crafted from top quality materials can significantly enhance both patient and clinician satisfaction. The choice of alloy combination used to manufacture an abutment screw is a crucial factor influencing the long-term prognosis of the implant abutment connection, as an advantageous preload helps prevent abutment screw loosening, as noted by Schwartz in 2000 and Pardal Palez Montero in 2017. However, It's worth noting that determining the frequency of screw loosening remains a challenging problem, as highlighted by Taylor in 1998. The chemical composition of an abutment screw alloy holds paramount importance. Surprisingly, even minor alterations in the chemical composition of an alloy can significantly affect the modulus of elasticity and the tensile strength, as observed by Piermiotti in 2006. Differences in screw strength among various manufacturers and between different lots of screws produced by the same manufacturer can lead to inconsistent and conflicting clinical observations, as reported by Rumblier in 2002. Considering that the chemical elements of an abutment screw alloy may leach into the surrounding tissues, as demonstrated by Towser Smith in 2017, it is imperative that manufacturers disclose and publish the chemical composition of their abutment screws to ensure informed and conscientious decisions by clinicians, demonstrating transparency and integrity. I would like to encourage my colleagues to take action and collectively urge their respective implant companies to provide this essential information for the benefit of clinical health and ethical considerations. Notably, most studies have demonstrated that gold abutment screws outperform titanium abutment screws, as summarized in Table 2. Please note that the manufacturer termed 3i Implant Innovations and Biomet 3i consolidated since 1999 and are therefore equivalent. However, Tsugi and Hagiwara in 2009 presented an open to discussion finding that claimed that titanium alloy abutment screws were less likely to loosen due to their increased preload following cylindrical loading. However, when we drilled down into the methodology and data, several factors could have contributed to this unique result, including differences in chemical composition and torque values applied during testing. Furthermore, it is crucial to recognize the consolidation of 3i Implant Innovations and Biomet 3i since 1999, as research by Rumblier in 2002 focused on the same manufacturer as Tsugi and Hagiwara. This consolidation is significant as it revealed variability in the physical properties of similar hex gold prosthetic screws made by the same manufacturer, potentially impacting clinical success. The bottom line is that if you change the chemical composition of the abutment screws, you alter the performance. In research by Martin in 2001, the gold alloy screw investigated comprised of 80% palladium, 10% gallium, 10% copper, gold, and zinc, raising concerns about the use of gallium and palladium compounds which are associated with health risks. Consequently, it underscores the importance of transparency regarding the chemical composition of abutment screw alloys. So in conclusion, the choice of abutment screw design and material is a critical factor in the performance and longevity of implant systems. Manufacturers should openly disclose the chemical composition of their abutment screws, and clinicians should consider various factors including alloy composition, torque value, and implant system design to make informed decisions regarding abutment screw selection for the best clinical outcomes on their patients. Abutment screw loosening has been reported at various frequencies by different authors. Neert in 92 reported 5% incidence, Becker in 95 found a higher rate of 38%, and Jung in 2012 reported 8.8% incidence. Goodacre in 2003 noted an average loosening rate of 25% with early screw designs, which decreased to 8% with new screw designs. In a systematic review that we performed covering the period from 1990 to 2003, the overall screw loosening rate was calculated as 4.4%. Interestingly, it was observed that the rate of screw loosening and fracture increased by 0.61% per year during this period. This indicates that despite advancements in screw design, clinical complication of screw loosening and fracture has not improved significantly. Historically, the Brannemark concept used gold alloy abutment screws. However, nowadays, manufacturers are increasingly offering and using titanium abutment screws due to their cost effectiveness. Some manufacturers have even exclusively included titanium abutment screws in their catalogs. One possible complication for the persistent issue of screw loosening and fracture despite improvements in screw implant design could be the increased use of titanium alloy abutment screws. These titanium screws may lack the advantages offered by gold alloy abutment screws, such as a higher modulus of elasticity, greater preload values, lower coefficient of friction, and more stable implant abutment connections. This hypothesis calls for an in vitro comparative studies to investigate this further. The loss of preload, as discussed by Samos in 2002, can be mitigated by retightening abutment screws approximately 10 minutes after the initial placement. Cantwell in 2004 identified that the fall in preload resulted from embedment relaxation, localized plastic deformation, and torsional relaxation, which is the loss of rigidity due to twisting. Importantly, they found that a significant portion of the preload loss occurred within the first 15 hours. However, 29.5% happened within the first 2 seconds and 40.2% within the first 10 seconds. In a clinical setting, it is advisable to take this data and to retighten freshly placed abutment screws either within a few seconds or a few minutes after post-fitting, or alternatively the following day, whichever is practicable. In summary, over the defined period of my study, the overall mean rates were as follows: screw loosening at 4.4%, screw fracture at 1.77%, and the combined fracture and loosening rate was 6.17% of all implant screws. Unfortunately, there has been no significant improvement in this common complication of screw loosening and fracture despite technical advancements, with an annual increase of 0.61%. To address this issue, implant manufacturers should disclose the chemical composition of their abutment screw alloys, which has a critical clinical relevance to patient health and biomechanical performance. Clinicians should reduce the risk of screw loosening and fracture by selecting abutment screws made from alloys strategically chosen for their favorable preload characteristics. Gold alloy abutment screws are the preferred material for securing the implant abutment connection due to their higher modulus of elasticity, greater preload values, lower coefficient of friction, and the resulting more stable implant abutment connections. Clinicians seeking more cost-effective options can consider using titanium abutment screws with dry surface lubrications to achieve optimal preload values. To counteract the initial loss of preload, clinicians should vigilantly retighten freshly placed abutment screws for a second time shortly after placement, whether within a few seconds, a few minutes, or the following day, depending on practicality. Additionally, clinicians should be cautious of look-alike components that may result in less than desirable preload and screw loosening due to their poorly finished interfaces. These clinical recommendations aim to enhance the stability and longevity of implant systems by addressing factors related to abutment screw loosening and fracture. Thank you for your time listening to what I've shared. It's crucial that we support one another, exchanging information to leave a positive impact on this world. If you have a specific topic in implantology that you would like me to discuss, please feel free to reach out. If you find our content valuable, please consider liking and subscribing to help us grow this educational platform. Remember that the road to good health is paved with evidence-based scientific research, and keep smiling.